Namaskar. Welcome to our Heartline, the Voices of Cardiac Anesthesia. Today, in our episode 6, we will be talking about the inotropes in cardiac anesthesia. Either it will be helpful for the patients or it is not helpful, that will harmful for the patients. So the mode of teaching of class today is we'll be presenting a case first, then we'll be discussing about the inotropes, the uses, the side effects, where to use, where not to use, and at the end of the at the end we'll be discussing another type of cases that is useful in our day-to-day ICU practice, that is a general ICU practice. So starting with our first case, that is a patient, Mr. A, 62-year-old male patient, has been diagnosed with a triple vessel coronary artery disease with a good ejection fraction of LV ejection fraction of 60% without any other significant echocardiography findings, who will be elected for on-pump coronary artery bypass grafting. So what happened intraoperatively? The CPB time was around 82 minutes. The aortic cross-clamp time was 58 minutes. And there was three grafts, that is Lima to LAD, RSVG to RCA, and OM. So at the end of the surgeries, that was uneventful. And during weaning from the CPB, the patient developed hypotension, that is mean arterial pressure around 50 millimeter mercury, with a low cardiac index around 1.6 per minute per meter square, with a tachycardia, that is the heart rate of around 110 per minute. So what we can see in our transesophageal echocardiography, there is a global hypokinesia and the left ventricular ejection fraction that was previously 60% reduced to around 30%. And there is no regional wall abnormalities from new territories or the territories which have been grafted. Now the CVP is increased 12 millimeter of mercury with the SVR around 700 dynes per second per centimeter square. That is a low SVR. So what management is initiated according to the guidelines? We have initiated a infusion of dobutamine that is started around 5 mics per kg per minute. Why it has been initiated? As to improve the contractility of the heart and to reduce the afterload. That is mediated through the beta 1 and beta 2 actions. That is a predominantly beta 1 actions. So we'll be discussing the mechanism of action of dobutamine and all the anatopes afterwards. And the secondly, we have additionally started norepinephrine that was initiated around 0.05 mics per kg per minute. So why it has been initiated? To support the SVR and to maintain the coronary perfusion pressure for this kind of patients. And what was the other supportive measures we have taken? We did the calcium correction, and you can keep in mind that calcium is also an inotropic agent. Optimization of preload along with the fluids, that is the fluid guided fluid has been given to the patients according to the central venous pressure and the urine output. And we have done the acid base balance corrections, and we have reassessed the condition of the LV function every 10 minutes with the help of the transesophageal echocardiography. And the outcome in the postoperatively, with time, the patient has improved. Cardiac output improved to 2.4 liter per minute per meter square with the mean arterial pressure stabilized using the inotropes around 70 millimeter mercury. And we have been successful to wean the patient from the cardiopulmonary bypass, and the patient shifted to ICU on dobutamine and norepinephrine infusions. So, what is the problem the patient had? It is the low cardiac output syndrome. So, we have to recognize the low cardiac output syndrome very quickly, very early, so we can start the treatment as early as possible. And according to the ASA guidelines, dobutamine is the first line of inotropes in global hypokinesia in post-CPB patients. And norepinephrine is often required to support the mean arterial pressure when the vasoplasia coexists with the fall of the BP. That is a low cardiac output with the vasoplasia. the norepinephrine is indicated along with the dobutamine. And use of TE. So why the TE was so much useful? Because we can differentiate between the hypovolemia versus myocardial dysfunction patient versus cardiac tamponade patient. So TE is very useful in these conditions to rule out any hypovolemia is present or not, any myocardial dysfunction is present or not. And gradual weaning of the anadrops post ICU after the patient has been recovered and extubated, depending on the myocardial recovery, it was very smooth and the patient was extubated. So we will discuss about the low cardiac output syndrome first, along with the different kind of inotropes we are having, and there's some newer that is the very recent inotropes that is being used or being in experiments. So, Reshmi, can we start our discussion with the inotropes now?
Yes, ma'am. So,
Okay.
in a patient who has undergone a cardiac surgery, we consider an uneventful recovery when the cardiac index is greater than 2 liters per minute per meter square. The pulmonary capillary bed pressure is below 20, heart rate below 100, SVO2 more than 65%, and the patient has warm, well perfused extremities, a proper mental status, and excellent urine output. So these are the factors which depends the on which affect the MVO2, and which includes the heart rate, contractility, wall tension, preload, afterload, and ventricular radius. So all the inotropes which we will be talking about are somewhere or the other controlling all of these, any one of these criterias. So this is the cardiogenic shock classification done by the Society of Cardiovascular Angiography and Interventions. These are the 5 stages. Stage A talk about at-risk patients. Stage who is currently experiencing not experiencing any sign of symptoms of cardiogenic shock, but is at risk. Stage B is a patient who has clinical evidence of hemodynamic instability. Stage C is someone who manifests with hypoperfusion of the peripheral organs and who requires one intervention, either pharmacological or mechanical, beyond volume resuscitation. Stage D is a deteriorating or doom state in which the patient is in category C, but it is getting worse beyond the perfusion is the initial strategy is not helping. And stage E is extreme, actual or impending circulatory collapse. So, according to these papers and guidelines, a low cardiac output syndrome has been defined as the need for mechanical circulatory support with intra-aortic balloon pump, lead ventricular assist device, or extracorporeal membrane oxygenation during or after surgery, and or hemodynamic instability requiring pharmacological support with more than 2 inotropic medications on postoperative day 1. In general, it is termed as shock in a patient after cardiac surgery. These are the usual risk factors for low cardiac output syndrome. As we can see, patients who have had a prior cardiac surgery, they are at an increased risk. Ones who have an atrial fibrillation pre-existing or a pre-existing pulmonary hypertension, patients who have already had a history of cardiogenic shock immediate post pre-operatively, and specifically both systolic and diastolic, which means a patient with an EF less than 35%, and patients with CABG and valvular surgeries together. Postoperative complications in patients who go into low cardiac output syndrome include myocardial infarction, bleeding requiring reoperations, acute kidney failure, prolonged mechanical ventilation, discharge. Most of them are like discharged to the home hospice centers mostly, and most patients experience death. So, classification of inotropes as described by Dr. Deepak Tempe, it is of 2 types, adrenergic and non-adrenergic. Adrenergic includes catecholamines and non-catecholamines. Catecholamines can be natural as in adrenaline, noradrenaline, and dopamine. And catecholamines can be synthetic as in isoprenaline, dobutamine, and dopexamine. Non-acting, non-catecholamines directly acting, phenylephrine, methoxamine, ephedrine, mephentermine, and noradrenergic PDE inhibitors, milrinone, amridone, enoximone, and pyroxenone, and miscellaneous include digoxin and calcium. I will be coming to these slides later. So, what are inotropes? They are the ones which affect the strength and contractility, increases the myocardial contractility, increases the strength of muscular contraction. So, negative inotropic agents are also present, which weaken the force of muscle contraction. Both positive and negative inotropes are used in the management of various cardiovascular conditions. One of the most important factor affecting inotropic state is the level of calcium in the cytoplasm of the muscle cells. Positive inotropes usually increases this level, while negative inotropes decreases this level. The various positive inotropic agents which increase the myocardial contractility are used in conditions such as decompensated chronic heart failure, cardiogenic shock, septic shock, myocardial infarction, and cardiomyopathies. The agents include calcium sensitizers like levosimendan, cardiac myosin activators like omecamtiv, and catecholamines like dopamine, dobutamine, dopexamine, and epinephrine, isoprenyl, norepinephrine. Also includes cardiac glycosides like digoxin, phosphodiesterase inhibitors like milrinone and amrinone, prostaglandins PGE2, and glucagon. Negative inotropic effect mostly are dealt with here are the beta blockers. The other agents are calcium channel blockers, class 1 antiarrhythmics like quinidine, and class 1C antiarrhythmics such as flecainide. Now, the adrenergic agents mostly act by the alpha 1 adrenergic effect by the vascular smooth muscle contraction, and they also have some amount of alpha 2 adrenergic effect which leads to vascular smooth muscle relaxation. Beta 1 adrenergic effects, like which include direct ionotropy, improving cardiac contractility, and chronotrophy by increasing heart rate. And the beta 2 effect is present, which leads to vasodilation and bronchodilation. Dopaminergic effect is brought about by the dopaminergic agents by vasodilation in the kidneys, intestine, and the heart. This is a summary of all the adrenergic agonists. We can see here which has a more action on whichever receptors. It has been mentioned here. Accordingly, based on the receptors, the pharmacological actions of the drugs have been mentioned here. So these agents help to increase the SVR and blood pressure. It increases the myocardial contractility and enhances stroke volume. So we have been knowing these terms chronotropic, dromotropic. So chronotropic basically means it affects increases the heart rate. Lusiotropic means it increases the relaxation during diastole and reduces the end diastolic pressure in the ventricles. Dromotropic means affects conduction speed through the AV node, increases heart rate, and bathmotropic means it affects the degree of excitability. When injected, so firstly we'll talk about calcium. When injected IV, it produces intense positive inotropic effect for 10 to 20 minutes. And as stroke volume and LVEDP is reduced, reduces the heart rate and the systolic vascular resistance. Inotropic effects of calcium are enhanced in presence of pre-existing hypocalcemia. It is given at the dose of 5 to 10 milligrams per kg to adults, may be administered to improve myocardial contractility and stroke volume at the conclusion of CPB. Myocardial contractility at conclusion of CPP may also be reduced by hypocalcemia because of the use of potassium containing cardioplegic solutions, administration of citrated stored whole blood, and treatment of metabolic acidosis with sodium bicarbonate. So then we're going to talk about the calcium sensitizers, which include levosimendan, which is also a positive inotropic drug. The other drugs are pymobendan, sulmazole. It increases intracellular CAMP or calcium concentration. As a result, the interaction between actin and myosin filaments is increased, and the myocardial contractility increases. So desensitization of the myofilaments or to activate the effects of calcium may occur during myocardial ischemia, and stunning occurs. So these drugs like levosimendan are useful in these situations. The PDE3 inhibiting properties of myofilament calcium sensitizers produce arterial and venous dilatation that likely also contribute to the positive inotropic effect of these drugs. So here is a chart which shows how levosimendan acts on the circulation and the heart. In the heart, it helps in increasing the calcium sensitivity of contractile proteins, and in the circulation, it helps in opening the calcium ATPase channel and leading to vasodilation. Loading dose is 6 to 12 micrograms per kg over 10 minutes, followed by continuous infusion of 0.05 to 0.2 micrograms per kg. So peak effects are observed within 10 to 30 minutes of infusion. The duration of its action is around 75 to 78 hours to 1 week. So no dose adjustment is required for mild to moderate renal failure, but it may be required with moderate hepatic impairment. It is contraindicated in patients with severe renal impairment, severe hepatic impairment, severe ventricular filling or outflow obstruction, severe hypotension and tachycardia, and those patients who have had history of polymorphic VT, like in Torsades. Common adverse effects include headache, hypotension, arrhythmias, myocardial ischemia, hypokalemia, and nausea. Potential limitations include headache and hypotension and severe hypokalemia. Then we have catecholamines like dopamine, epinephrine, and norepinephrine. They are endogenous. Dobutamine and isoprenoid, as we have previously said, they are synthetic. So these are the actions, the receptors at which these agents act. Dopamine, we know in low dose, it increases the renal blood flow and reduces proximal tubular sodium absorption. In moderate dose, it increases the contractility, but there is minimal change in heart rate and SVR, but there is increased renal blood flow and increased splanchnic blood flow. And more than 10 micrograms, it leads to alpha action by leading to vasoconstriction, and its effect on the renal blood flow or splanchnic blood flow is reduced. So it is in treatment of shock, it is used to improve the cardiac output, blood pressure, and to maintain renal function. Often used with a vasodilator, which reduces the afterload and further improves the cardiac output. And it is, however, pro-arrhythmic. Now we come to dobutamine, racemic mixture of two isomers for both beta 1 and beta 2 receptors. Primary cardiovascular effect as it increases the cardiac output and reduces the PVR caused due to beta 2 activation, usually prevents much of the increased arterial blood pressure. I will be coming to that later again. Favorable effects of myocardial oxygen balance are believed to make dobutamine a choice for patients with the combination of congestive heart failure and coronary artery disease, particularly if the PVR is elevated. It should not be routinely used. Why it should not be routinely used, I'll be coming to that again. Dosing and it is usually 2 to 20 microgram per kg per minute. So dopexamine is a structural analog of dopamine again, because of it, but it has a less beta 1 adrenergic and alpha adrenergic effect. And then we are talking about epinephrine. It is an endogenous catecholamine which has direct stimulation of beta 1 receptors. SBP increases, but beta 2 mediated vasodilation in skeletal muscle may reduce the diastolic blood pressure. Beta 2 stimulation also relaxes the bronchial smooth muscles. So the beta 1 predominant activities are here: increases the heart rate, reduces the duration of systole, increases myocardial contractility, is a peripheral arteriolar dilator. Renal blood flow has neutral effect, increased renin secretion, and neutral effect on the splanchnic blood flow, and increased glucose and may cause hypokalemia. High dose will lead to alpha 1 action and reduce the renal blood flow and splanchnic blood flow. Complications, it can cause cerebral hemorrhage, coronary ischemia, ventricular dysarrhythmias, and should be carefully used with volatile anesthetics such as like halothane, as it can promote the dysrhythmic effects of epinephrine. Dosage 0.05 to 1 milligrams IV depending on the severity of the cardiovascular complications. It is available in vials with these concentration as in 1 in 1000, 1 in 10,000, and 1 in 1 lakh. Local anesthetic solutions containing 1 in 2 lakh to 1 in 4 lakh less systemic are available, which have less systemic absorption and longer duration of action. It is contraindicated, however, in patients of hypertension and pheochromocytoma, and should be cautiously used with heart failure. So a little bit about isoprenaline. It is non-specific pure beta agonist with minimal alpha adrenergic effect. SBP may increase or remain unchanged, but beta 2 stimulation reduces the PVR and DVP, which increases myocardial oxygen demand while decreases oxygen supply, making it or any pure beta agonist a poor inotropic charge. This is like it has a negative inotropic effect. It is, however, indicated in cases of bradycardia and decreased cardiac output and in situations of bronchospasm. Norepinephrine we have already discussed last class. Prostaglandins depend activity of the SNS relative to PNS and the metabolic status of the heart. PGE2 produces an increase in heart rate and myocardial contractility by direct inotropic effect as well as by increasing reflex activity. So dinoprostone is the agent which produces increase in heart rate and cardiac output. Cardiac glycosides like digoxin, extracted from the foxglove plant Digitalis lanata, is widely used in the treatment of various heart conditions, namely atrial fibrillation, atrial flutter, and sometimes heart failure accompanying with atrial fibrillation. It is usually the drug of choice. However, its positive inotropic effect includes directly on the heart and changes the electrical and mechanical activity. So this is a comparative study between digoxin and digitoxin. So Aubain is 1.5 to 3 microgram per kg IV to provide rapid increase in the myocardial contractility or to decrease the heart rate in rapid ventricular response to AF. So how does the selective phosphodiesterase inhibitors act? They exert competitive inhibition on an isoenzyme fraction of phosphodiesterase uh, enzyme, and which reduces the hydrolysis of CAMP and CGMP, increases concentration of CAMP and CGMP in myocardium and vascular smooth muscles. There is stimulation of protein kinase C, phosphorylate substance, and inward movement of calcium into the cells. So, positive inotropic effect with vascular and smooth muscle relaxation is present due to inhibition of cardiac PDE3 and leading to increased myocardial CAMP. Okay, so these are the various drugs which are used: amrinone, milrinone, enoximone, and pyroximone. So this is a study which is showing between norepinephrine and dobutamine in patients with reduced cardiac index. They have said that norepinephrine and dobutamine as a combination is better and more reliable and safer strategy, as epinephrine in itself increases lactic acidosis and increases heart rate, and also potentiates arrhythmia and inadequate gastric mucosal perfusion. This is another trial which which is showing whether intravenous dobutamine is useful in patients or not. So the patients have been grouped into two groups. One is the intravenous dobutamine, another they have been given placebo. It has been seen that dobutamine itself was an independent risk factor for death after adjusting for baseline differences. So we will be coming to milrinone. Like amrinone, it is a positive inotropic and vasodilator effect. It has minimal effect on heart rate and myocardial oxygen consumption. It increases cardiac output by improving contractility, reducing SVR, PVR, and has a lusotropic effect and decreases preload due to vasodilation. And it is unique in beneficial effects of RV function. Studies are there which support the same. Half life is 1 to 4 hours, and elimination is primarily renally excreted. Loading dose is 50 micrograms per kg over 30 minutes, followed by 0.25 to 0.75 microgram per kg per minute. So, this is a study which has compared milrinone with dobutamine in the treatment of cardiogenic shock. It has been seen that in the milrinone group, there has been no significant, in both the groups, there has been no significant difference with respect to the secondary outcomes. Whereas in support to the primary outcome, as in all cause hospital death, resuscitated cardiac arrest, receipt of cardiac transplant, and non fatal myocardial infarction, has been lesser in the milrinone group as compared to the dobutamine group. Again, there was a comparison of between milrinone and dobutamine, which has said that the left ventricular ejection fraction did not reach any significant difference, but the LVETD, left ventricular end diastolic volume, was static in case of the dobutamine group, but in case of the milrinone group, it had reduced. Also, the mean pulmonary arterial pressure had a significant reduction in milrinone group. The pulmonary capillary wedge pressure significantly reduced, and the transpulmonary gradient also significantly reduced. So this is a famous study which has established milrinone, which says that In patients who pediatric cardiac surgery patients, there were three sets. One set was receiving low dose milrinone, another set was receiving high dose milrinone, and another set was placebo. So prophylactically, in those patients who were at a higher risk of going into a low cardiac output syndrome, in those patients, those who have received a high dose milrinone has reduced the relative risk of composite endpoint, that is death by or LCOS, by around 48%. So they are saying preemptively in pediatric cardiac surgery patients we may use milrinone in a higher dose. So coming to levosimendan, it increases the sensitivity of the heart to calcium, thus increases cardiac contractility without a rise in intracellular calcium. Also, as I said, the vasodilatory effect by the potassium gated ATP channels in the peripheral vessels. So this is again the same. Okay. So this is a trial which was done, which is a famous survive trial between levosimendan and dobutamine. It has said in the levosimendan group there is a greater decrease in BNPs at 48 hours. Also, the decrease persisted over 5 days, but there was a higher incident of cardiac failure in the dobutamine group. Whereas in the levosimendan group, there was a higher incidence of atrial fibrillation, hypokalemia, and headache in the levosimendan group. So then we have the Optim CHF trial for patients. So this shows that levosimendan is more useful in the non-ischemic patients as compared to the ischemic group. This study also says the same, that levosimendan. Sorry, this is the Revive One trial, which is saying that in the initial 24 hours, levosimendan is useful as compared to placebo, and when other diuretics or other drugs are added to control heart failure, in those cases also levosimendan has been proved beneficial. But for cardiac surgical patients, levosimendan has, especially patients who have undergone valve surgeries, they in these patients there is a lower rate in, so there has been in patients with reduced LVF undergoing cardiac surgery or bypass did not result. So there was no significant improvement in the outcome. However, there was significant hypokalemia and hypotension. It has been seen that levosimendan helps in improving the uh, right ventricular function, that is the systolic function of the right ventricle, compared to milrinone, which helps in reducing the pulmonary arterial pressure, and more compared to levosimendan. So this is something which is called as the vasoactive inotrope score, which is very useful. A VIS score of more than 20 in immediate postoperative period is considered fatal for the for the cardiac outcome. See, these are the other inotropes which are used. It is a highly selective PDE3 inhibitor and increases myocardial contractility. This is a comparative study between levosimendan, milrinone, and dobutamine. Levosimendan also has a potent action on the coronary artery. It acts as a vasodilator. But it is milrinone and dobutamine, both of them are notorious for their arrhythmogenic activity. So glucagon, it's a polypeptide hormone produced by A cells of the pancreas. It enhances formation of CAMP, evokes the release of catecholamines. It increases myocardial contractility and heart rate in the presence of beta adrenergic blockade. Like if there is an overdose of beta blockers, it is then that we use glucagon. Uh, it has less effects as compared to dopamine, but it also has some amount of renal effects. Side effects include hyperglycemia and paradoxical hypoglycemia, hypokalemia, nausea, vomiting. Beta blockers, I think we'll do it in the next class when we'll be discussing heart failure medicines as the negative inotropic effect. So, what is an ideal positive inotrope? It will enhance the contractility without any significant increase in heart rate preload. afterload, and myocardial oxygen consumption. It will enhance the diastolic function, maintain the diastolic coronary perfusion pressure, and thus an adequate myocardial blood flow. It should also have a rapid titration time and onset of action and a short half life. Catecholamines have been known as the mainstay of current inotropic treatment. They can be divided into more potent as an epinephrine, isoproterenol, noradrenaline, and milder dopamine, dopexamine, and dobutamine. So, what are our anesthetic goals? For patients with reduced or depressed systolic heart function, anesthetic goals are monitoring of cardiac function, avoiding sympathetic responses, optimization of preload, afterload, monitoring and maintaining heart rate and rhythm, inotropic drugs. Postoperative management would also require monitoring in an intensive care unit. So, postoperative myocardial infarction, myocardial dysfunction is significant impairment in ventricular performance commonly occurs after cardiac surgery. The EF may diminish to 35% or to 75% of their pre-CPP levels, along with decreased cardiac index. Following cardiac surgery, the effect is similar to myocardial stunning, as ma'am had previously said. It's a global hypokinexia, and thus it is reversible. The heart undergoing this type of surgery is subjected to ischemic and reperfusion injury also by oxygen free radicals, which can also be a cause, as well as myocardial edema. They all lead to myocardial stunning. So, post stunning may involve both right and left ventricles. Weaning from the CPB represents a critical phase in which the eventual ventricular dysfunction may fully appear and inotropic support may be required. So, a biphasic pattern of myocardial depression may occur from the initial compromise after separating, and a second period of low myocardial performance, about 3 to 6 hours maximum after separation from the CPB, may be present. The time to full recovery is approximately 8 to 24 hours, and it returns to baseline function is often delayed in patients with worse preoperative ventricular function. Postoperative ventricular function affects systolic and diastolic function. So these are the predictors of inotropic need in patients. As I have previously mentioned, the risk factors. There can be ventricular dysfunction can be due to myocardial that is the revascularization injury, ongoing acute ischemia, some new onset ischemia, surgery related myocardial stunning, or pre-existing myocardial dysfunction. As we all know, as I have already mentioned, evidence of inadequate tissue perfusion are the signs of shock which we'll be looking into, with a slow capillary refill time, weak or thready pulse, cold and clammy peripheries, tachypnea, tachycardia, hypotension, metabolic acidosis, oliguria, or anuria. So, what is the choice of the inotrope? The ideal positive inotropic agent should be enhancing contractility of both the right and the left ventricle without any significant rise in the heart rate, preload, afterload, and myocardial oxygen consumption. And it also enhances diastolic function. Should have rapid onset, short half life, and can be titratable. This is during CABG. Inotropes may be needed in case of pre-existing ventricular dysfunction, and also as the definition goes, there can be associated intra-aortic balloon pump required. In emergency revascularization of acute myocardial infarction, dobutamine and PDI may be the most beneficial inotropes, and it should be started 5 minutes before the termination of CPB. This compromises the starting the infusion of inotrope agents too soon increases myocardial oxygen consumption while the heart is being reperfused on CPB. So this compromises the energy stores and serve no purpose. Other than that, in chronic heart failure, there is beta 1 receptor downregulation with reduction in receptor density. So, and also there is low intracellular levels of CAMP. So catecholamine is used. A combination therapy of PDI and beta-adrenergic inotrope like dobutamine or epinephrine may be used. And depletion of myocardial stores of norepinephrine also occurs in chronic dysfunction. So when marked ventricular hypertrophy is present in cases of severe aortic stenosis, hypertrophic obstructive cardiomyopathy, the use of beta-adrenergic agents may worsen the diastolic function. In valvular surgeries, again, in aortic stenosis, it may be used, but in chronic aortic insufficiency where there is ventricular dilatation and dysfunction, There should usually requirement of adequate preload and inotropes. In mitral stenosis, we have to be careful about the heart rate. So therefore, we should be very careful when we are titrating the inotropes. In acute aortic and mitral regurgitation, they both pose a great risk of severe ventricular dysfunction after surgical correction and requiring inotrope support even preoperatively. So it's also used in heart transplant patients and lung transplant patients. So in cardiogenic shock complicating acute myocardial infarction, there are various ventricular arrhythmias, contraction, band necrosis, and infarct expansion. Critical hypertension itself compromises myocardial perfusion, leading to elevated left ventricular filling pressures and increased myocardial oxygen demand. Definitive treatment measures. Inotropic agents may improve mitochondrial function in non-infarctive myocardium. So here, as far as the American College of Cardiology, dobutamine acts as a first line of agent if systolic blood pressure ranges between 70 and 100 in the absence of signs and symptoms of shock, whereas dopamine in patients who have the same systolic blood pressure in the presence of symptoms of shock. When response to medium dose of dopamine or dobutamine in combination is inadequate or the patient's presenting systolic blood pressure is less than 70, the use of norepinephrine has been recommended. So, this is heart inotropes in sepsis. Little points about inotropes in pregnancy. Indications and usage of digoxin is not altered. Same dose of digoxin will yield lower maternal values during pregnancy than in non-pregnant. Fetal levels approximate those in the mothers. When IV inotropes are required, the standard agents can be dopamine, dobutamine, norepinephrine can be used. Fetus is jeopardized as all agents is increased resistance to uterine blood flow and can stimulate the uterine contraction. Little information is known about the PTIs. So, what are the future inotropes? One is glucagon that we have talked about. Istaroxim. So, istaroxim is investigational drug which is a steroid derivative. It increases the contractility by inhibiting the sodium potassium ATPase and stimulates the SERCA2A protein, which helps to increase the contraction and increases relaxation peripherally. However, it also has potentials of reduced arrhythmia and is presently a part of the Horizon F2 trial. Omecamtiv mecarbil is a selective cardiac myosin activator. It stimulates myosin ATPase and increases fractional shortening of myocytes without increasing intracellular calcium. The increasing myocyte shortening is associated with an increasing time to peak concentration, and it is also in the like point of clinical trial ongoing. Nitroxyl, it is a protonated analog of nitric oxide. It mechanism of action is independent of CAMP or protein kinase signaling with no modification of L-type calcium channel activity. And specific cysteine reduces on either phospholamban or SERCA2A, resulting in augmented sarcoplasmic reticulum calcium uptake. Ryanodine receptor stabilizers. Abnormal leak of calcium through ryanodine receptor not only increases the availability of calcium for contraction, but also affects the diastolic function. Moreover, it can also trigger arrhythmias. Gene therapy is also coming up to increase the sarcoplasmic reticulum calcium pump activity, and energetic modulators are also coming up, some of which include nesteride and carperetide. They are synthetic ANP and BNP modulators. They help in reduce causing vasodilation and acts as diuretics and regulates fluid and electrolyte activity. So these are the recent advances. There is also an ongoing trial which shows that capital dodemy trial, which is saying that whether at all inotrope is required or in a cardiogenic shock, it is still in the level of trial. And this is another low dose dobutamine versus single dose tocilizumab, which is being used in acute myocardial infarction with high risk of cardiogenic shock. And these drugs I've already spoken of. Ma'am, over to you.
Yes, excellent presentation, Rashmi. It was so informative and vast. Very, very good. Very, very elaborate and very nice presentation. So can you name two conditions where we do not use inotropes?
Ma'am, in which patients?
You can name me two conditions, two cardiac conditions where we do not use inotropes.
Ma'am, one of them is in a
Like
hypertrophic
we do not
cardiomyopathy.
use, yes,
So in
very
hypertrophic
good, very
cardiomyopathy,
good.
we prefer to use phenylephrine compared to
What
the
will
other.
happen?
So, ma'am, so in the
Please,
is the so the gradient will increase. The gradient in the LVO2
yes,
OTO will increase because of the increased heart rate or
yes.
and the increased
So in case
contraction.
of HOCM, the yes, the aim of our treatment is to uh, give a much of fluids so that the LVOT remains open and to reduce the heart rate. So it will not be obtained with the use of inotropes primarily. And
Yes,
in
ma'am.
case of a severe aortic stenosis, where the LV is much thickened and it's a very hypertrophied heart. And the third condition, as per ASA guidelines, we don't use inotropes in case of heart failure patients,
Okay. Also, ma'am,
specifically the chronic heart failure patients.
also, ma'am, in cases of pediatric patients where in TOF, in those situations, if we are using more inotrop, it will only lead to a more amount of spasm, infundibular spasm. So in those patients also, we should avoid inotropic action.
Yes, very good, very good. So any questions about up to this, the explanation of the ionotropes? So we can come to the next case. Rashmi, can you just show you the slides because the
Yes,
case
ma'am.
is there.
I'll
The
just
last
come.
case is there.
Yes, yes, ma'am.
So we can come to our second case, that is the patient, Mr. B, a 48 years old female, Mrs. B, I'm sorry, and she is having chronic thromboembolic pulmonary hypertension. The procedure that has been done by lateral PTE under deep hypothermic circulatory arrest. So what happened in the immediately post-operative ICU? The heart rate was 105, mean blood pressure was 65, and the CBP is much uh, much higher. That is a 20 millimeter of mercury. And the echo findings, Rashmi.
Yes, ma'am. Eco findings.
So we can see in our echocardiography findings that is the patient having dilated RV with a moderate RV dysfunction, LV compressed with a D shape of the septum with a high pulmonary arterial pressure, that is a 45/20, and post-operative fall from pre-operative 85, it was a 80 to 80, 45, but it decreased from the pre-operative part, but it is still elevated with a lactate it's like within normal is 3.5 millimole per liter. So how can we manage this case? So as per Rishmi has taught us, we can use milrinone, that is we have to use inotropic and vasopressor support for the patient. We can use milrinone with a, because the patient is having already having hypotension, we can avoid the loading dose. We can start the maintenance dose first, that is the infusion. Usually we start milrinone at a dose of zero point 0.3 mics per kg per minute. We can if possible we can put a PA catheter for other patients, or we can see the CBP and the urine output for the measurements of the function of the preload functions, LV preload functions. So the Miliron, what will do? It will improve the RV contractility and reduces the pulmonary vascular resistance by doing a pulmonary vasodilation. So it will help for the patients. And along with the Miliron, we will be using norepinephrine at a dose of 0.05 to zero point 0.1 mics per kg per minute. Why? To maintain the coronary perfusion and the systemic pressure without increasing the pulmonary vascular resistance. This is the beauty of milrinone and the norepinephrine combination. We can use vasopressin with a low dose, that is a 0.03 units per minute. That is usually used for the vasoplegic patients without worsening of the pulmonary hypertension. So what happened with this treatment? What happened with the patient? Rishmi, next slide, please. So we also have to maintain the other supportive measures in the ICU, like ventilation with a low pulmonary low PEEP. That is pulmonary. And what will happen if we increase the PEEP? So it will cause it will uh, it will cause
Oxygen.
pulmonary hypertension. It will elevate the pulmonary hypertension by uh, inflating the alveolus. So if we increase the PEEP, that will elevate the pulmonary arterial pressure along with the pulmonary vascular resistance. So we'll be keeping low PEEP. We can use inhaled nitric oxide along with that 10 ppm because it will be very selective pulmonary vasodilatation. And we have to monitor the RV functions via serial echocardiography because echocardiography assessment of the RV at least 3 to 4 times a day will help us to titrate our RV functions. We'll be gradually tapering the vessel pressures very slowly over 48 hours as the RV functions is getting improved. We can use the fusimide along with that if there is decreased any so that the preload will a bit decreased so that it will decrease the preload of the RV. That will help to improve the RV functions gradually. So what happened with the patient? The lactate has been normalized by day 2. We can wean the millinone slowly, gradually after day 3, and the patient was extubated on day 4 with the stable hemodynamics. So thank you very much for today's class. Any question? সৈকতদা আছো? Any question from anyone? Otherwise,
Hmm. Hello.
হ্যাঁ
Hello.
দাদা বলো।
Hmm. Uh,
হ্যাঁ
I
বলো।
think
Any question?
what is the what is the role of the negative inotropes? Why you use the negative inotropes and why you use the term negative inotropes?
As it decreases the heart rate, the term was like negative inotropes, but actually it is not not that it will decrease the uh, it is actually decrease the heart rate, thereby decrease the myocardial contractility, but it will help otherwise in case of heart failure patients that we will be discussing our next class. It will ultimately by chronic use it will help the heart to remodel and increase the cardiac function. So this is a sort of a inotrope with
Yes.
negative action, immediate negative action, that is a decreasing heart rate and the myocardial contractility. So it has been termed like this.
Okay. But how can it help in a acute situation? Post operative?
যেটা হয় post operative, the heart rate is so important. So if you decrease the heart rate, it will allow the heart to fill, that is the diastolic function will be better, and the diastolic filling will be better. So
Feeling also better.
ultimately
Okay.
it will
Increase
filling
the
better,
forward
and
flow.
thereby it will increase the cardiac output. Yes, yes,
Okay.
sir. That is the way they help by increasing the cardiac output.
Okay. Next, I said, what about the
Okay, there
dobutamine
is.
and
Huh.
noradrenaline? How much dobutamine after
Mhm.
we increasing the dose, we switch over to the norepinephrine? Any specific guideline?
এটা
So
বলছে
not
যে if you হ্যাঁ বলো বলো।
Sir, noradrenaline is usually used to support the vasodilatory effects of dobutamine in a titrated fashion. We give dobutamine as per the requirement of the patient to get the
Okay,
optimum cardiac output. And if there is an associated vasoplegia because of dobutamine, then that is counteracted by the action of noradrenaline. So it is titrated accordingly to reach a desired SVR and a cardiac output.
Okay. So first we start dobutamine, and then we go to the higher dose of the dobutamine. At the same time, we also start the norepinephrine
Yes,
if
sir.
the HDL low is low.
So studies have shown that on starting dobutamine and norepinephrine together is a better combination if other than starting adrenaline, especially in cases of right-sided ventricular failure, as there are reduced levels of lactate and reduced perfusion abnormalities in the peripheries.
Yes, but at the same time, noradrenaline also increase the resistance against the cardiac contractility
Yes, sir. So
due to
it has to be a low dose noradrenaline.
low dose
Low dose
noradrenaline.
noradrenaline.
Okay. I say everyone, if the situation is post-operative heart failure in non-cardiogenic operation, then the same guideline we follow. Any deviation from that?
Dada, we use the same guidelines. It is the American Society of Anesthesia guidelines, ASA guidelines. It is the same for all. এগুলো যেগুলো নেওয়া হয়েছে সেগুলো ওই গাইডলাইন্স থেকেই নেওয়া হয়েছে. So we
Oh,
can use the
so we can
হ্যাঁ
also follow this guideline in case of
same
non-cardiac
guidelines
surgery.
for
Non-cardiac surgery also.
yes
Okay.
একদম একদম.
Okay. Thank you. Thank you.
And this class is oriented about the is as আচ্ছা সব সব তোকে আচ্ছা ইনসুলিন ইনসুলিন খুব ভালো প্রশ্ন করেছো ইনসুলিন am I
Yes, ma'am, you're audible.
Yes. Well. Not audible.
তুমি
Yes, ma'am.
yes um so what I am just explaining the insulin, the role of insulin as an inotropic agent, it will promote the glucose uptake from the cardiomyocytes, and insulin increases the sarcoplasmic reticulum calcium uptake and release, and therefore it is enhances the calcium dependent contractility, and thereby it helps as a increasing myocardial contractility without increasing the myocardial oxygen consumption. Apart from these two effects, it has a long-term effects that insulin is an anti-apoptotic agent and the anti-inflammatory agents. And it has been said that insulin also have a peripheral vasodilatation effect. That is, it reduces the afterloads and improves the coronary perfusion and the myocardial efficiency. So by four ways, insulin help us to increases the cardiac output. That is, firstly, the enhanced myocardial glucose uptake. Secondly, improving the calcium handling by the myocytes, and by chronic, that is the anti-apoptotic and anti-inflammatory agents, and it has also found to have vasodilatation effects. Shoptuke, is it clear? And also we have a insulin protocol for this thing that is called a HEAT protocol, HIET protocol for the dosing of the insulin as a that is we have to start zero point 0.5 to 1 unit per kg per hour infusions to have insulin as a inotropic actions. And the second question is in a patient postpartum cardiomyopathy, mm, immediately after LUCS ejection fraction of 40%, what will be the choice of inotropes? Uh, the patient have a postpartum myopathy, and it is the same that we have discussed till now. It has been taken from American Society of Anesthesiology. So the first line of inotrope will be dobutamine. Okay, and as we have discussed, if the mean BP is low, we have to elevate the mean BP by adding the norepinephrine. So dobutamine, first line of inotropes, the patients with low cardiac output with maintained BP. If the patient's BP is decreased, that is the mean arterial pressure less than 65, we have to add norepinephrine along with the dobutamine. Okay, so these are the first line drugs. Now, if the patients still are not recovered, we can, and the patient also have RV dysfunction and pulmonary hypertension along with the postpartum cardiomyopathy, we can also use milrinone or levosimendan along with these things. So we have to add norepinephrine along with the milrinone and the levosimendan if the BP is low. So based on the etiology, based on the hemodynamic profile, hemodynamic profile of the patient and the lactate status, this is very important. We have to see the lactate status of the patient so we can use these kind of drugs. Firstly the dobutamine. If the BP low, dobutamine plus noradrenaline, and if the RV dysfunction is there or pulmonary hypertension is there, we can use milrinone along with the norepinephrine or levosimendan along with the norepinephrine.